So thank you, Dr. Abdullah. So I think we'll talk a little bit about how to recognize a more common than we thought, but supposed to be rare disease. So amyloidosis is actually something that we diagnose as cardiologists a lot, but sometimes it has a lot of mimics, and I think we have to, when we look at the echo, we have to look at everything in context. So one of the things I'm going to talk about is something we're not familiar with as cardiologists is this, the carpal tunnel syndrome and cardiac amyloidosis. And this is actually a nice review article that came out from the Cleveland Clinic in Ohio about how numb hands are a window to the heart. So it's not just a pain in the hand, it's something else. So one of the things that comes out from this is that when you take patients with carpal tunnel syndrome bilaterally, and you actually take these tissues and you send them to biopsy, it appears that it's 5 to 15 years before overt cardiac symptoms. And it's much easier to get a biopsy from the hand than to get a biopsy from the heart. So it actually makes sense when you have patients with this phenotype is to make sure that the orthopedic or plastic surgeon actually takes this very seriously. And we need to know this as cardiologists because we're going to guide our other physicians to look at this as a primary early manifestation of cardiovascular disease. So we actually published a nice review article with the group from Cleveland Clinic, and we tried to integrate all of this into some simple clinical clues. And one other thing that we also looked at is when you do the large group of patients that we screened over the last 5 years, the screening test of choice is not the echo, it's actually the nuclear scan using a radioactive material that we typically use for bone scanning. It's called PYP. So you can do a bone scan, and if you see that agent in the heart, you know something is seriously wrong. So this is actually the review. Cleveland Clinic, Ohio started this in 2018, screening bilateral carpal tunnel patients for cardiac amyloidosis. And with that, they increased their yield quite significantly. And from a heart failure standpoint, I think the patients with HFpEF, many of these patients who seem not to respond to medical therapies probably have hidden cardiac amyloidosis. And I think this may sound a little trivial, but if you have a thick heart patient who has HFpEF, who's not responding to conventional treatment, and is an older and maybe a male with a thick ventricle, we need to think about this because this is a very easy test to do, and you can actually include these patients in an efficient treatment. Now, if you wait too long, the treatments take a long time, about 1.5 years to work, so you have to start thinking about and treating early, and early diagnosis is really important. So the test of choice that we're using for screening now, the echo just is an entry point, but to prove or disprove the diagnosis is no longer needed to do a cardiac biopsy. As a matter of fact, this PYP technetium pyrophosphate, which is a bone tagging agent, it's the same agent you use for bone scan, actually is 99% effective in making the diagnosis if it's positive, and you don't have to do a tissue biopsy. You also have to do a blood test to make sure the patient doesn't have monoclonal antibodies that come from the bone marrow, because there's a mimic called AL amyloidosis. So it is not as rare as we think. There's a lot of effective treatments. Cardiac biopsy is no longer needed in many cases, and the early diagnosis is possible if we collaborate with neurologists and orthopedic and hand surgeons, because patients with carpal tunnel syndrome have a very high yield if you look at their tissue biopsies from the hand, in fact, in cardiac amyloid. So the first thing to do with imaging is to suspect it before you do the echo. And if you tell your technician they have a thick ventricle, please give me a global strain, give me a very detailed assessment of the diastolic parameters. Don't miss the E to E prime ratio. You're going to find a lot of patients that fall into that suspicion. So that's the reason you're doing it. Secondly, if you're going to do the imaging, you have to do the blood to look for troponin, because these patients have troponinitis. There is no coronary artery disease, but there's apoptosis. This protein actually causes apoptosis of the myocardium cells, and you have a very high NT-proBNP than a patient who looks euvolemic, doesn't even have lower limb edema. Again, it's due to direct toxicity of the protein and relevant imaging, as I mentioned. So what are the things that we don't do as cardiologists so we can learn from this? Is these other things: orthopedic and musculoskeletal symptoms, extra cardiac symptoms. So bilateral carpal tunnel syndrome and what's known as a trigger finger, so somebody who's like this, and spinal column stenosis, rotator cuff bicipital tendon rupture, which I'll show you an example of Popeye's sign. In addition, things that are not related to the heart: peripheral neuropathy, chronic diarrhea, weight loss, a big thick tongue, periorbital purpura, and jaw claudication. So these are all signs of peripheral involvement. These are all signs of musculoskeletal involvement. What's going to be typical for us is these patients will come to you with HFpEF, with atrial fibrillation, with bundle branch block, complete heart block. They may need a pacemaker. They may have aortic stenosis. In fact, 15% of patients undergoing TAVR now are being discovered to have cardiac amyloidosis. And there's a lot of cardiac ways that these patients you can see without realizing that the LVH is not simply due to the hypertension or aortic valve disease. So remember to ask these questions. And if you have a patient with HFpEF that comes to you in a wheelchair, or a patient with HFpEF that has scars on both hands, that's really a red flag. It's really a very powerful finding. So this is the etiology of the protein. It actually deposits into these almost like crystals or fibers, and they deposit into the carpal tunnel years before it goes into the heart. It's very important to realize this, and this is something that we can use to predict the disease. So as a matter of fact, the earliest stage is the orthopedic manifestations, right here, right at the beginning, and it can actually precede any of the findings at least 10 years beforehand, before the MRI, before the echo. So it's very important to also have a systematic approach. When the orthopedic and neurosurgeons see these patients, bilateral carpal tunnel syndrome, at least send them to the cardiologist to take a look at their ECG and maybe go an echo. So when you do screening for cardiac amyloidosis and you look at those patients who had some evidence of carpal tunnel syndrome, you'll find that 4% in total, 21% of patients with cardiac amyloid had carpal tunnel syndrome, especially if they're over 70 and a BMI of less than 30. So a thin, older man with bilateral carpal tunnel syndrome and a thick ventricle, it's really 20% is a very high yield. Now going backwards, if you see patients with carpal tunnel syndrome on their own at the time of their surgery, you follow them over time, they will develop this disease. So it is an orthopedic link that I think we should make for us. Now, if you want to take a picture of this is the website, there's actually a very nice calculator. It's called Estimator. And if you're looking for patients with cardiac amyloid or you want to suspect it, this is how you can get a very high yield. So they actually got this from standardized registries, and they went back and gave us a nice calculator, like exactly a CHADS VAS score, if you would. You put in some values. So does the patient have heart failure or not? Is the patient, it's very small. Does the patient have thick ventricle? Do they have carpal tunnel syndrome? As a matter of fact, increased wall thickness only gives you a 2-fold risk increase, but the history of carpal tunnel syndrome or surgery increases the risk by 6 times in a patient with HFpEF. So really it is so valuable not to forget that history, or if you're examining the patient, checking their pulse, just take a look. What's the scar? So many registries have shown this point. The bilateral surgery may have been performed one time, and then years later they had the second one. All of this precedes the heart failure prognosis as well. And in fact, the conclusion is if you screen cardiac amyloid in patients with prior carpal tunnel bilaterally, especially the older males, at least 5% will have transthyretin, higher in males, non-obese, over 70 years old. So this is what it looks like when they actually take the tissue from the biopsy itself of the arm, the carpal tunnel. You see the Congo red stain. This is also called Sirius red, and this is the immunohistochemistry, which is showing nodules of TTR depositing in the myocardium. In the carpal tunnel, not the myocardium. So there's very important. And I realize, having talked to orthopedic surgeons, it's not standard for them to take these biopsies. They don't do it. They just clean it out and they throw it away. So you really have to tell them, at least send this tissue for biopsy, and this is really kind of a key point. Also, of the other non-cardiac manifestations is peripheral neuropathy. If you go backwards in history in patients with cardiac amyloid, 15 to 30% have peripheral neuropathy. In other words, they're going to see the neurologist long before they come and see us in cardiology as well. And gathering specimens during carpal tunnel release surgery is strongly recommended in the guidelines. When you do the biopsy, they don't just need to stain it for what? Hematoxylin and eosin. The common pathological stain doesn't work here. You have to ask them to specifically stain for amyloidosis. So they have to inform the pathology department to do immunohistochemistry, electron and mass spect. It is not detectable with standard hematoxylin and eosin. They have to specially order the Congo red or thioflavin T, and it's also not routine to do this thing, which is the fluorescent light microscopy. So you can get the Congo red and you have to see the polarized light by refrigerants. So it requires them to do this, otherwise it's going to be ignored. So this is the H&E. Can you see this? This is H&E. You cannot see the nodule. When you go to Congo red stain, you can see it kind of faintly, and there it is. Now if you use higher magnification with the polarization, there it is. You can see the big green dot in the middle of the tissue. So this is a really important thing. Now they also can use thioflavin T, which is another analog of Congo red, and it's much simpler and more obvious to see. So this is an endomyocardial biopsy. So with the H&E, you don't really see it. You just see this sort of vague pink structure here. But when you do the Congo red staining, you see the deep pink red coloration. So even if you do a cardiac biopsy, and I've seen this happen, we don't request the Congo red, the pathologist doesn't do it, you're going to miss it. You have to request this special staining. Okay? Now, my question is, which is easier and safer to obtain, a cardiac biopsy or a hand biopsy? Really, I think that's fairly obvious. So this is a picture I borrowed from one of my friends who's a hand surgeon, and you can see the difference between that, where you're basically dissecting in a superficial way with a microtome, versus taking a cardiac biopsy. I think it's fairly clear what you can happen here. You can have a lot of complications from this. And as I mentioned, in 2023, it is almost unnecessary to get a cardiac biopsy. What I'm trying to say is with the cardiac carpal tunnel syndrome, you can get all of this information 10 years earlier and not subject this patient to this kind of miserable situation. So it's not just this pain in the wrists. There are many other orthopedic manifestations of transthyretin amyloidosis that precede overt heart failure. So I'm going to show you some examples, but this is the natural history. In fact, the development of trigger finger is the earliest probably, bilateral carpal tunnel syndrome, lumbar spinal stenosis, and then you start having myocardial infiltration. So this is actually a very late stage, and we really have an opportunity here to try and find these patients fairly early. So where's the Popeye sign? There it is. So Popeye's sign is this one. So you know who's Popeye, right? He's his spinach? Yeah. Okay. So you see when you just do this gentle movement of the upper extremity, this bunches up because the tendon is ruptured. So this is bicipital tendon rupture. It ruptures here, so the whole muscle tracks upwards. And this is the same patient when we did the nuclear scan. This is a bone scan. Okay? This is a bone scan. The sternum and the heart and the ribs are all taking up, but the heart has the massive uptake. You see it? So you have a bone scan agent that's lighting up in the heart. This is the actual amyloid protein that is developing this calcification almost. In addition, they can have this thing called the shoulder pad sign, the scar in this patient, and you can see this thickening of the rotator cuff. So a lot of manifestations that are orthopedic that I think we have to educate our orthopedic doctors about. Now, the coexistence of carpal tunnel, lumbar spinal stenosis, and rotator cuff tears can certainly predict the presence, and this is percentages of almost 33% when you're talking about lumbar stenosis, rotator cuff, and CTS. Okay, so here's actually a patient, and this is not one of our patients because I don't have a patient with spinal stenosis that we've biopsied. Lumbar magnetic resonance imaging, see the stenosis here along and the thickening of the ligamentum flavum. You look at the ECG, it doesn't look very impressive, but there is biatrial enlargement, and there is some evidence of poor R wave progression in V1 and V2, maybe a Q here, maybe a pseudo R wave. But this is the patient's echo. It's very thick, and you see the speckled appearance. And here we see the famous cherry on top. So if you're not doing global strain, you really have to have your technicians do it. It's a very simple thing. It adds only 1 or 2 minutes to the acquisition. And you see there is a markedly reduced global longitudinal strain except at the apex. So this is a very classical finding if it's done properly. And when you do the cardiac MRI, you actually see the transmural late enhancement. There's also failure to null. This is the T1 map. It's extremely enhanced. But here is the screening test. You don't need to do a cardiac MRI for the diagnosis. You actually have to do this PYP scan. And you see the bone tagging agent is almost all accumulated within the myocardium. So this is the guy's history. He actually had spinal stenosis and lumbago, but not heart failure. But he didn't walk much because of his back. Later on, after almost 7 years, he started to develop carpal tunnel syndrome and had surgery. And then 17 years later, he developed a left ventricular hypertrophy, which was discovered at the time of his pre-op clearance for spinal surgery. So natural history is just right there. So this is a biopsy from the patient's ligamentum flavum, Congo red, and the polarized light. The myocardium was biopsied a little bit later. So this could have been done years earlier when he had his initial spinal surgery. So it comes back to the bones. Bone scanning agents and nuclear scans are actually the gold standard. Okay. So essentially what we're looking here is the cardiac uptake. And you see in this patient also the uptake in the wrists. If you look in the bone scan, the uptake is in both wrists as well. So bone scintigraphy has actually revolutionized the diagnosis. You do not have to have an invasive biopsy at all. When you look at it from a nuclear scan, this is the light up there. It's very intense, more intense than spine as a matter of fact. And there are some false positives and false negatives, but this is a 99% accuracy if you do the correct tracer material. This is a normal patient who has no uptake in the myocardium, and this is a patient with, one of our patients actually, with intense uptake over here. So this has really saved a lot of patients having a myocardial biopsy. So just one real quick thing, because we are cardiologists and these are things that are going to encounter. So is it only a disease of males? This is not true. Females can have it in 18%. Is it only low voltage? This is actually not true. You're more likely to have atrial fibrillation and a pseudo-infarct pattern than low voltage. Low voltage is a very advanced form of the disease. So if you have a normal voltage, don't exclude the presence of amyloidosis. Now, LVH, is it symmetric or asymmetric? It can be any pattern. It can be symmetric or asymmetric. Can you have a restrictive pattern? Absolutely. You have a pericardial effusion, 42%. And the other problem is this. Why do we need to take care of this medicine? I wasn't taking care of it when I was in medical school. When I was a fellow, it was just a rare thing. Because it actually have medications that improve survival of these patients, I think it's very imperative upon us to actually do these kind of follow-ups so we can follow the patients as well. Okay? And this is the last thing I want to leave you with, when to think about TTR amyloid. Any patient with a thick ventricle, more than 12 millimeters, and that seems almost like normal, but it is very important. And patients with low or decreasing voltage on ECG, patients with the sensory and
30 seconds, yeah.
this we're almost done. This is the last one.
30 seconds.
Okay? So, low or decreasing voltage with a thick ventricle, hypotension in somebody who's previously been taking hypertensive medications. If you have heart failure with preserved ejection fraction and a thick ventricle, I know it's a common phenotype. If you look at the ECG and there's pseudo Q waves, AV block, and the other issue, of course, is if you have late enhancement on an MRI that seems in an unusual pattern. From a biomarker standpoint, very high NT-proBNP and persistent troponinitis in patients who don't have coronary artery disease and appear to be euvolemic, and of course, all of the extra cardiac manifestations that I discussed earlier. All right, thanks a lot.
Thank you very much.